Good morning. Welcome to the 11th Annual Cholangiocarcinoma Foundation Conference. I want to thank you for being here today and thank you for your involvement in this event. We have about a little over 525 attendees this year, and we'll have about double or triple that virtually, so thank you for being here with us. There is a virtual platform that we're using this year called Chime. You should have received an email on Monday with your login information, and if you can't find that, then please just go to the registration desk and they will help you. My name is Stacy Clements Lindsay. I am the CEO of the Cholangiocarcinoma Foundation. We are so happy to have you join us here in beautiful Salt Lake City, Utah. I want to first thank the sponsors who have made this event possible. These are the companies that are developing drugs to help you, and they are here. There are 22 of them, and they are here in the hallway, so please thank them. Please visit their booths, and they want to hear your stories, and they want to share with you the things that they're developing in their pipelines. We're really excited about that. Today is Wear Green Day. If you're not wearing green, the CCF store is right outside. Feel free. We're happy to get you all, get that all reconciled. And thank you for all of you who are so supportive. I want to talk with you just about a couple of things on the agenda. The agenda for this conference is always shifting because flights get canceled and different things happen. So I just want be sure that you're checking the online platform, and there's also the online kind of a billboard, a virtual billboard outside. And so check that for any updates. You will notice that we've had a little bit of a rebranding after 18 years. And so there's new CCF gear and all kinds of things in the store again, so you can do that. Also wanted to make sure that you're aware that we do have a giving tree outside as well. This is the first year that we've done that. And I want to thank Bill Sessions, who is a caregiver for his wife, Cheryl. He is going to match $10,000 to the first $10,000 that are donated for that. And there's all kinds of CCF staff to help you do that. Thank you to Bill. You can do that at the CCF booth. You can do it on the conference platform. There's QR codes everywhere, so feel free to do that. We would appreciate the help getting more research and more patients to the conference. Just a couple of things. There's also the CCF booths are on this far side, and there are a couple of things that you can do that are really important as patients here. The scientists are in the basic science room. That room is packed full. There are scientists from all over the world there working for you. They're from Uganda and Ireland and Scotland and the UK and Canada and Nigeria. They're from everywhere, India, everywhere, and they're here trying to work this problem and get solutions for you. Please thank them for being here. They're taking their personal time to be at this conference to work on this disease, and we're so grateful that they're here. Also, I just wanted to let you know, at the CCF booth over here on the left-hand side, one of the things that you can do to help those researchers and scientists is join the patient registry. It's a very simple process. There's a whole table there. They will help you through that process, but that will help us move the research forward. That's something that you can do. Also, if you don't have a biliary emergency information card, there's also a booth over there that will help you do that. If you have stents and drains, if you're having any kind of procedure, then there's a chance you can get ascending cholangitis. It can be very dangerous. The biliary emergency card is similar to like a cardiac card when you have a heart procedure. If you have to go into the emergency room in the afternoon, or not in the afternoon, but on the weekend, or you're not going to your regular doctor, the little card has a QR code that will tell them exactly how to treat ascending cholangitis. And so please do that as well. We want you to be safe. Just a couple things also. On the virtual platform, there's a place where you can share your story. Your story has power. And we thank you for all of you who participated last night in the dinner and shared your stories. Your story has the power to change hearts and minds. And many of the scientists and the researchers, the clinicians, the regulators that are here will not have interacted regularly with patients. Especially those, we have a lot of new pharma partners. please share your stories with them. There's something really meaningful about them meeting the patients and really putting that passion into their work, and that's what we want. So I want to introduce our chairs. This is Dr. Angela Lamarca. She's going to come up in just a minute, and Dr. Mitesh Borad. Dr. O was unable to be here because of a medical association difficulty in their healthcare system. So and she's sad not to be here, but she's here. And then Sumera Elias and Daniela as well, who are managing and co-chairing the scientific session. So thank you. Thank you. This is a lot of work. It's a big lift to chair this conference and to get, there's a lot of things in motion, so we're really grateful for them for doing this. Okay, I want to introduce Dr. Angela Lamarca is a medical oncologist who specializes in gastrointestinal malignancies and neuroendocrine tumors. She completed her training in medical oncology at the hospital in La Paz, Madrid. She moved to the Christie NHS, that's in the UK, in 2013, where she completed a fellowship program. She is now back in Spain, in Madrid, since 2022. She was awarded an ASCO, which is the American Society of Clinical Oncology Conquer Cancer Foundation Young Investigator Award in 2017 and in 2018. That's one of the biggest Young Investigator Awards in the world, so this is a superstar. The Christie, she continues her clinical and translational research career in HPV and NETs, and her aim is to achieve a better understanding of pancreatic biliary tract cancers and NET malignancies, and to identify new treatment strategies for improving patient outcomes. So thank you, Dr. Lamarca.
Well, thank you very much for that very great introduction. And well, they gave me the opportunity to summarize in 15 minutes, they said, all the research that is going on in general in cholangiocarcinoma, and I will probably mention a little bit also of what is happening in biliary tract tumors. I think they have my slides that they should come up at some point. And the aim is really for you to have a little bit of an overview of what is happening in research in cholangiocarcinoma, but also how many questions we still have unanswered. And you will see that there are so many things that we don't really fully understand, but that we are trying to understand better. So I will go slow, well, not slowly, I will go quite probably quickly through everything. And the aim is really to have a little bit of a flavor of everything that is going on, so you can see that the effort is really at very multiple levels. So these are my conflict of interest. So this is the slide I kind of built for us to go through the main topics where we are putting a lot of effort, investigating, understanding, asking new questions, finding new answers that, again, they bring up new questions as well. One of the very big problems we have in cholangiocarcinoma and biliary tract tumors is the fact that the diagnosis is usually late. So this means that for majority, unfortunately, the resection is not a possibility. And we heard earlier that even without not having a surgery doesn't mean that you cannot live, and that is something really important. But still, of course, the more we can resect, the better. And the earlier we can diagnose, the more we will be able to resect. So one of the main topics where we are trying to improve, and the beginning of this wheel that you have here, is how can we improve this early diagnosis. And there are some data that almost half of the patients diagnosed with a biliary tract tumor don't really get not only surgery, but to any treatment. So an earlier diagnosis really is going to improve resection, but also potential options of treatment. What are we doing? Well, there is a lot of research ongoing for developing new biomarkers, doing a new understanding of something that maybe we can find in the blood, so we can identify who has a higher risk of developing biliary tract tumors, and also new and more modern imaging techniques to identify lesions that may be a little bit challenging to identify, for example, in patients who may have a primary sclerosis cholangitis. Understanding the risk factors is something that we don't fully understand in biliary tract tumors or cholangiocarcinoma, and without risk factors, we cannot really do a screening. There is no mammogram for cholangiocarcinoma. We need a mammogram for cholangiocarcinoma, and we should find the patients who should have that type of testing moving forward. We must do this because the incidence is increasing, and this, as we very, very well know, is a disease where we really need to improve the diagnosis and improve the benefit that we derive from treatment. This is a very recent publication. It's one of the samples of something that I was mentioning earlier about a liquid biopsy or markers that we can find in the blood that can actually identify people, healthy people, who may have a higher risk of developing a biliary tract tumor. And by doing this blood test, maybe we can identify in whom we should do this type of mammogram or a screening test. Once we have the diagnosis and we do a surgery, the adjuvant therapy is the treatment that we are usually administering after the surgery. The problem is that we do have a standard treatment with capecitabine, but still the relapse rate of the risk of the cancer coming up is too high, and we must improve this as well. It's something where a lot of research is going on. There are clinical trials ongoing, exploring not only new options of chemotherapy, like, for example, the cisplatin and gemcitabine being compared with capecitabine. This clinical trial should be able to report the results very soon, in 1 or 2 years. But there are also new clinical trials being designed with immunotherapy. As we will hear later on, immunotherapy is now part of the standard treatment for advanced disease. And what we wonder is which could be the role of immunotherapy in the adjuvant setting. Should we also use it after resection? Right now, this is fully experimental, but it's something that, again, is being investigated in clinical trials. And targeted therapies, we were also in the meet and greet hearing about biomarkers and people knowing exactly what biomarkers they have, because we have treatments for these specific molecular alterations. So which is the role of these treatments in the adjuvant setting? Should we use them after surgery? Again, we don't really know that, and clinical trials are being considered in that setting. This is some data from the BILCAP clinical trial, and what I want you to see is the limited benefit we have from capecitabine. There is a benefit. We offer this to every patient, but this is something that we really, really must improve, and we need new options of treatment. This was one of the latest studies on the adjuvant setting being reported. It's a small study, so we don't fully trust these results, and we are awaiting, as I mentioned, a larger study. But I wanted to show you this because it's an example of how slowly we are really moving forward, but still moving forward. This was a smaller study comparing, as I mentioned, the capecitabine with the cisplatin and gemcitabine. Results were not as expected. We thought we were going to see a clear benefit in favor of the cisplatin and gemcitabine, but we didn't see this. And this is why participating in clinical trials is so important, because sometimes what we think is common sense, of course 2 is going to be better than 1, is not later on being replicated in clinical trials. A larger study is trying to show whether this negative trial is true, or whether with more patients and with a larger statistical power we can actually change that paradigm. Neoadjuvant therapy. Neoadjuvant is the concept when we use a treatment for a disease that cannot be resected, when what we need is to make that tumor smaller so we can later on do a surgery. We are far away from speaking about a proper neoadjuvant strategy in biliary tract tumors, but again, there is a lot of research ongoing looking into potential options. First, defining what is resectable and what is not resectable. Different centers will have different opinions, and this is sometimes because there are no specific criteria to follow for definition of this, something that we, for example, have in pancreatic cancer. So there is a big effort and work in progress for this definition of resectability. But there are also ongoing clinical trials, because if we have a tumor that we cannot operate because it's too big, which is the best option of treatment for that tumor? We don't really have the answer to that. So again, new options of chemotherapy or new options of local regional therapy, like the hepatic arterial, intrahepatic arterial, intrahepatic, well, anyway, the HYPE, sorry. I cannot even say it, is one of the new options of treatment that is being explored also in clinical trials. And of course, the transplant, we have also mentioned the transplant before in the meet and greet, and it's something hot topic coming up and more having a specific criteria in different countries. This is one of the examples of the clinical trials with neoadjuvant chemotherapy, small steps, but slowly moving forward for us to understand which is the benefit of chemotherapy in this specific topic. And the hepatic arterial infusion pump, sorry for me, it's like I don't know what time is the jet lag, is really starting to be shown to show some activity in clinical trials. So slowly maybe we can consider this something really a standard of care. I did mention immunotherapy. Immunotherapy has been one of the very big topics coming in the field of biliary tract tumors and cholangiocarcinoma, and is now considered a standard of care combined with chemotherapy, always combined with chemotherapy, with cisplatin and gemcitabine for patients who have not received a previous chemotherapy. But we don't really know who are the patients who are going to benefit the most, or we don't really know what to do when the chemotherapy stops working and we change to another chemotherapy. Should we maintain immunotherapy? There are no really data to do that. So a lot of clinical research is going in the field of defining how can we know who is the patient who is going to benefit more, how can we make a patient who may not benefiting, so how can we change, this is what we call changing the tumor from cold to hot. How can we make a tumor responsive to immunotherapy if it wasn't responsive before? And what shall we do with immunotherapy moving forward? First step with immunotherapy is the definition of biomarkers, and this is a recent publication where the real message is just that we don't really know much about biomarkers of immunotherapy in biliary tract tumors. The quality of the data we have, the studies that have been done in this regard for many, many years are not of very, very good quality, and they are also quite small. And this is why now a lot of the research ongoing is in this topic. New biomarkers, for example, the microbiome, the bugs that are in our stools and in our GI tract, they can have an impact on how immunotherapy works. If we change that, can we change the impact of immunotherapy? These are ongoing open questions. And also radiomics, or looking at the scans from a different point of view with machine learning, for example, can we learn more about how immunotherapy is going to work by doing that? As you see, it's a very, very broad field by looking into the tumor, to looking into the scans, and also trying to identify how can we change the response to this immunotherapy. A lot of questions ongoing in there. New targets, because we were speaking about targeted therapy. So targeted therapies is, after doing all the molecular profiling and the molecular testing, we know that there are some specific alterations, but the reality is that we don't find alterations that we can use as targets in all the patients. Ideally, we will want all the patients to have something for which we have one specific drug. But this is at least now far from reality, and we want to make that a reality in the coming future. How can we make that? Well, we do that by doing a very wide NGS panels to identify these alterations, to hopefully identify more and more targets for which we can develop new treatments and new drugs. And we are being successful in doing that, and you will hear, and I will show you, of a few biomarkers that a couple of years ago were not even mentioned in a cholangiocarcinoma conference, and that right now they have already come up in the meet and greet. They are already in the agenda for the basic research, and I will mention them here. So things that are really coming and appearing on a yearly basis. We are also targeting more in a clever way targets that were old. For example, the HER2. HER2 is something that has been targeted in breast cancer for many, many years. And now in cholangiocarcinoma and biliary tract tumors, we are targeting HER2 also, but not maybe with these standard drugs that we use in breast cancer, but also with new compounds that have been defined more specific for targeting HER2 in a more clever way. So not only new targets, but also targeting the target the targets we know in a more clever way. And of course, new indications, and we heard about FGFR already, but we don't really know which is the role of FGFR inhibitors in the first-line setting. Is always after chemotherapy. So understanding how can we move these treatments in the first-line setting is also something very important. Example of targets, as I mentioned, MDM2 amplification is not something that we were mentioning in the past as a biomarker of interest, and now is a biomarker of interest for which we have a specific clinical trials with promising activity. The MTAP loss as well is something that is already in the agenda for the basic research, because we have noticed that a proportion of cholangiocarcinoma tumors do actually have this alteration, and we can actually target these with some of the new drugs that are being developed. Almost 20% of the cholangiocarcinoma seem to have this MTAP loss. Still early days for this biomarker, but something that is coming up, as I mentioned. And the HER2 is not only targeting the HER2 with trastuzumab that has been used in breast cancer for many years, but multiple different drugs being tested, and a lot of these trials including patients diagnosed with cholangiocarcinoma and biliary tract tumor, something really, really important. I did mention the first-line treatment is not only important to understand that a drug is working, but also to understand which is the best moment for us to use that compound. And for example, right now, the FGFR inhibitors, they are being used after chemotherapy, but should we use them earlier? We don't know. And this is, for example, one of the ongoing clinical trials, the 5301 clinical trial looking into the role of 5302, looking into the role of the FGFR inhibitor in the first-line setting before any chemotherapy. Once we have targeted treatments that are approved and funding, which on its own is a huge effort and takes too long, we know that there are also resistant mechanisms, and that at some point, the tumor kind of learns how to fight that specific treatment. So we must really understand how can we overcome that resistance, and a lot of effort in research, translational research, is going into understanding this primary and secondary resistance. Primary resistance means that even if you have the alteration, maybe the treatment doesn't work for you. Why is that happening? We don't fully understand, but we are doing a lot of research in that regard. Secondary resistance means that when the treatment works, it stops working. Why does it stop working, and what can we do to overcome this? And again, we are trying to understand this. We are trying to understand this first by looking into other alterations that may be happening, and this is why we always like spending some time into this molecular report. So we are not only looking into the alteration of interest, but also the other alterations that can maybe explain to me who is going to respond better or worse. And also by doing some translational research associated to all these ongoing clinical trials is very important. And this is, for example, some research looking into how we can identify this FGFR fusion in the blood and how this is changing, and actually new mutations appearing that can explain why this drug stops working in one specific situation. New drugs are coming also to overcome this resistance, and we have, for example, that nengotinib is an example of a new FGFR inhibitor being developed in the setting of resistance to other FGFR inhibitors, with a phase 3 clinical trial ongoing in patients with cholangiocarcinoma, so something very specific in this disease. And finally, my last minute is going to go to mention the fact that this is not only cholangiocarcinoma, but also biliary tract cancer. Most of everything I said includes or is coming from clinical trials where also gallbladder cancer and ampullary cancer were included. And I don't think we should really forget all these other two entities, because all the three of these are actually all the biliary tract tumors. There is a big effort in understanding the differences between these different biliary tract cancer. New registries being developed for some of these specific biliary tract tumors, because it's really important that we also move forward the field for those. And this is kind of my take-home message. I think we are learning a lot, but the more we learn, the more we know that there are things that we don't really understand. New answers bring new questions, but we really are working hard and doing our best all together to really answer those questions. And I just wanted to mention that over the last year, a lot of effort has been done in Spain. There was no patient association until very recently. The first meeting was October 2023, and this is a picture of that small meeting where a few patients came together, and I just wanted to congratulate them because as of the 15th of February 2024, we have in Spain a 2BB, which is the Spanish Patient Association that I would really hope you will support. I'm here, the chair, representing Europe, and I also wanted to mention the huge effort from the researchers. ENSCA is the European Network for the Study of Cholangiocarcinoma, and I am part of this network as well. And we have a lot of ongoing collaboration and a recent awarded cost action funding also to move the field of biliary tract tumors forward. And I wanted to say thank you for giving me the opportunity of co-chairing this meeting today, because it's always a great pleasure to collaborate to the Cholangiocarcinoma Foundation. Thank you all very, very much.